Okay, that last video cut off, I was talking about hemoglobin from hemolyzed red cells. This happens if you get a blood transfusion that's not properly matched. And then myoglobin is protein in muscle. When muscle is crushed, myoglobin can be released into the bloodstream, can end up in the kidneys and damage the intrarenal component. Infections like pyelonephritis, acute glomerulonephritis, sepsis, pancreatitis, and peritonitis can also end up damaging the kidneys, either the infective agent itself or toxic substances from, for example, sepsis or the pancreatitis can get into the bloodstream and damage the kidneys. In something like sepsis, you may have a double situation where you have toxic stuff get into the kidney, but you also have vasodilation going on that reduces renal blood flow. Glomerular disease, these would be conditions that actually damage that glomerular unit. Post-streptococcal glomerulonephritis, that's an immune-mediated response to a strep throat infection or strep skin infection. And the immune response can end up producing it can produce a response that damages that glomerular unit. Hemolytic uremic syndrome was probably covered with your PEDS content. This is the most frequent reason for acute kidney injury in children. It is caused by the E. coli infection, and along with the kidney damage, those kids also have profound anemia and thrombocytopenia. Ischemic necrotic acute tubular necrosis. In this situation, the blood flow has been diminished to the kidneys to such a degree that the basement membrane can be affected. In hepatorenal syndrome, this is associated with patients who have liver failure. It's not real clearly understood, but it's thought that a combination of the systemic vasodilation and renal vasoconstriction that happens in liver failure ends up producing a situation that allows the kidney to fail. Toxemia of pregnancy is another known situation that can cause kidney failure, as is malignant hypertension. In malignant hypertension, the blood pressure goes so high that the vasculature in the kidney system clamps down so tightly, and or the high pressure in the system damages the kidneys. Now, we talked a lot about what the urine and the blood looks like in someone whose low urine output is due to a pre-renal situation. And the key in pre-renal situations is to identify and correct so that an intrarenal situation does not develop. Certainly, you can have intrarenal renal failure because of a pre-renal situation that was not corrected. If it's corrected, we can just say pre-renal oliguria or acute kidney injury of a pre-renal cause, and it has a quick turnaround. In intrarenal oliguria, the causes that we mentioned before, all these things here that are known to be nephrotoxic or in some way damage the kidney proper, produces the kidney failure. In addition, a pre-renal situation that is not corrected will eventually damage the proper kidney, and then you have intrarenal. So, in intrarenal oliguria, what you see is blood urea nitrogen and creatinine increasing, and they're increasing proportionately. So they're both elevated, but that 10 to 15 to 1 ratio is maintained. Remember, in pre-renal, the body is actively conserving urea nitrogen. It's actively pulling it back because kidneys can. They're not broken. In this situation, the kidney itself is broken, and so it cannot pull back anything. The only reason that these things are the way they are is because the kidney's not working right. The kidney is not filtering urea nitrogen. It's not filtering creatinine. So those those substances are retained. So in this situation, urea is retained versus in pre-renal, urea is actively being conserved. Now, urine sodium goes up in intrarenal conditions because the kidney is broken. It can't conserve the sodium. The specific gravity becomes fixed, and what that means is that it becomes like your plasma. Now, for all and any of us, our urine has the capacity to concentrate and dilute depending on how much water we drink. So through the night, I don't drink water when I'm sleeping, so my body actively conserves water and the urine that is being made is more concentrated. During the day, I drink water and so my urine is probably more dilute. You know, over time, the net specific gravity of your urine is probably going to be a little bit more than plasma because the goal of kidneys is to eliminate waste. And your body has a degree of efficiency, so it does conserve water when it needs to. In this situation, when the kidneys are broken, the ability to concentrate urine is not there. And so the urine becomes fixed. Well, what I mean by that is the specific gravity of the urine becomes fixed. And that's an indicator. It may look bad. The urine may look concentrated because it's got a bunch of stuff in it, but it's not, well, gosh, I said stuff. That's really not what I mean. It may have cells in it and casts in it. It may have protein in it, but it's not going to be a concentrated waste to water situation. Protein may also be spilled if the glomerular unit has been damaged. Postrenal causes. Anything that obstructs urine flow. Let's just take a prostate, for example. If I obstruct urine flow here, my bladder is going to get distended, my ureters get distended, the renal pelvis gets distended, and eventually the kidneys cannot filter products because it's got nowhere to go, and then the substances stay in the blood. Correcting the obstruction can very quickly resolve the renal failure as long as that obstructive process wasn't allowed to remain to such a degree that the glomerular units were actually damaged by the obstruction. So even post-renal causes can produce intrarenal damage resulting in true renal failure if not corrected.
Work quickly to assess your patient so you can pinpoint its cause and begin treatment. Your assessment findings may vary with the phase of acute renal failure. If your patient's in the oliguric phase, expect his urine output to fall sharply. Normally, urine output exceeds 30 milliliters per hour. In the oliguric phase, it drops to about 15 milliliters per hour. This decreased urine output usually occurs 1 to 7 days after the causative event. If the patient has severe tubular injury, he may develop anuria with a urine output of less than 50 milliliters in 24 hours. Urine output can fall because less blood circulates to the kidneys to be filtered. Or it can fall because damaged tubular epithelial cells collect and obstruct the tubules. When your patient's urine output is low, look for signs of intravascular fluid overload. First, measure his blood pressure, which may be high. Next, look for signs of heart failure caused by fluid overload. These signs include an S3 heart sound, pulmonary crackles, and jugular vein distension. Also assess for peripheral and central edema. They develop when intravascular fluid leaks into the interstitial space. Now observe your patient's breathing. He may have Kussmaul's respirations, which are rapid, deep breaths caused by metabolic acidosis. This complication occurs because the damaged tubular epithelial cells lose their ability to synthesize ammonia, or NH3. Normally, ammonia combines with hydrogen ions to form ammonium, or NH4, which is excreted in the urine. By promoting hydrogen ion excretion, ammonia helps maintain a normal blood pH. Without ammonia, hydrogen ions accumulate in the blood, lowering the pH. At first, bicarbonate, or HCO3, maintains a normal pH by combining with the hydrogen to form carbonic acid, or H2CO3. Then, carbonic acid breaks down into carbon dioxide, or CO2, and water, or H2O. Eventually, the bicarbonate supply is exhausted, and the damaged tubules prevent the formation of new bicarbonate. This results in hydrogen ion buildup and acidosis. To raise the pH, the body must remove more acid. So it tries to exhale extra carbon dioxide, which is a weak acid. And this produces the characteristic Kussmaul's respirations. Next, assess for neurologic effects, such as lethargy or confusion. These findings may occur when unexcreted urea and creatinine build up in the blood and produce toxic effects on the central nervous system. If your patient's in the diuretic phase of acute renal failure, you're likely to see his urine output exceed 400 milliliters per hour. In this phase, urine output increases because the glomeruli filter the blood, but the tubules can't concentrate the urine. Urine output also rises because of osmotic diuresis, which is caused by a high blood urea nitrogen, or BUN, level. Because diuresis characterizes this phase, assess for signs of fluid and electrolyte depletion. For example, check for dry skin and mucous membranes, and for arrhythmias. Arrhythmias may result from an electrolyte imbalance, such as hypokalemia. In the diuretic phase, large amounts of potassium and sodium are excreted in the urine. So hypokalemia and hyponatremia are especially likely to occur. And these electrolyte imbalances may trigger abnormal automaticity, causing an arrhythmia. If your patient's in the recovery phase, expect his urine output to gradually return to normal. This phase reflects tubule healing. It usually begins 3 to 4 weeks after the injury and can last for 6 months to a year. After assessing your patient, prepare him for diagnostic tests as ordered. First, obtain blood samples and urine specimens for testing. When the test results are ready, review them closely. In the oliguric phase of acute renal failure caused by ATN, expect